Fluids are drugs. With right approach, fluids can affect the outcome and prognosis of a patient. This is one topic almost every other doctor feels confused about: what to give, how to give, and for how long. We will see fluids through a new approach with revised concepts that will define how to look at fluid management in future. The first episode is about revised physiological baseline concepts. This will set foundation and tone for practical management episodes. With the sound conceptual foundation, in the next episode, we will discuss pharmacology and practical administration of fluids, taking pathology and case-based variations into consideration. Let's begin then. Let's quickly go through the traditional understanding of what you know already. Water makes 60% of total body weight. The functional compartment includes intracellular and extracellular spaces. In extracellular space, we have intravascular or plasma space, separated from the yellow-colored interstitium by a semi-permeable endothelium. Water moves by osmosis and diffusion between these three compartments to balance out osmolarities at roughly 285 milliosmol per liter in normal state. Such balancing act of water ends up making it 2/3 inside the cell and 1/3 in extracellular space. Of the 1/3 quantity in extracellular space, 3/4 of water is in interstitium while 1/4 in vessels. At level of capillary, Starling classic teaching states that 4 factors dictate whether water moves out, shown in green, called filtration, or whether it moves inside the vessel, called reabsorption, shown in purple. The agent of filtration include capillary hydrostatic pressure that push water out of capillary and colloid oncotic pressure of interstitium that pull it out into the interstitium. The factors causing reabsorption of water into the vessel from surrounding tissue include interstitial hydrostatic pressure. Usually this pressure stays negative in gel-like structure until the pressure becomes positive, which is called edema. Capillary oncotic pressure or pull generated by large molecules like albumin, globulin that prevent water filtration and support reabsorption. So remember this equation in simpler terms. If JV is the transcapillary flow, it's the hydrostatic pressure gradient between capillary and interstitium minus the oncotic pressure gradient that dictates the direction of transcapillary flow. In short, raising hydrostatic pressure or reducing colloid oncotic pressure of capillary will cause filtration of water from capillary to interstitium. Reduced capillary pressures, raised interstitial pressures, or raised capillary oncotic pressure will reverse the transcapillary flow and water will be reabsorbed by the capillaries. So as per traditional belief, at arteriolar end, where capillary pressure is high, transcapillary JV is increased and filtration occurs. With fluid moving out, proteins get concentrated, raising oncotic pressure at venular end, together with low hydrostatic pressure, so fluid is reabsorbed into vessel. The remaining fluid in interstitium is then cleared by lymphatics. But this old model doesn't explain a lot many discrepancies in practical terms, and this is one of the reasons we feel very confused about the right way of looking at fluids and their distribution. For example, it doesn't support why crystalloids needed to resuscitate acute hypovolemic is almost equal to the amount of colloid. It's only after normovolemia that crystalloids and colloids become 3:1. Similarly, this simplicity of Starling principle doesn't support why albumin administration doesn't reverse edema in septic or ARDS case. In revised Starling principle, we come to know it's not the endothelium that's semi-permeable membrane. Rather, there is a glycocalyx layer lining the inside of endothelial linings that acts as a barrier. The yellow highlighted area between the endothelial glycocalyx layer and endothelium is called Sub-Glycocalyx layer or SGL. The SGL at any time contains 700 to 1000 ml of fluid that can freely be passed into the plasma whenever required. So really the intervascular compartment has subcompartments between plasma volume making 5.5% and SGL space making almost half of plasma volume, which was hidden from Starling's original concept all this time. RBCs and protein molecules larger than 70 kilodalton cannot cross the EGL semi-permeable membrane, but water and electrolytes can freely cross it. The crystalloids contain water and electrolytes. Both can freely move through the glycocalyx layer, but the colloids, especially those with solute molecular weight greater than 70 kilodalton, cannot cross into the sub-glycocalyx layer. So it tends to stay in plasma volume. This is why colloids dilute the RBCs and hematocrit more than the crystalloids, which led to the false belief that major share of crystalloid infused leaves the vessels and enters interstitium, when really it is still in large proportion in intravascular compartment distributed between plasma and SGL. So SGL is a protein-free low oncotic pressure fluid and electrolyte space. Since the new semi-permeable membrane has shifted now to glycocalyx layer, the colloid oncotic pressure pull of SGL adjacent to glycocalyx is more important now. So revised equation substitutes colloid oncotic pressure of SGL for colloid oncotic pressure of interstitium. The fluid in SGL space lacks any proteins as said before. The value of colloid oncotic pressure of SGL is much lower, far lower than interstitial colloid pull. Now, as per the equation, this should technically reduce the transcapillary flow, right? Old model says filtration and reabsorption occur both at capillary level. In revised model, the filtration still occurs but lower amount than previously believed. No reabsorption occurs and the fluid filtered out into the interstitium is regulated further on by the lymphatics only. This is the steady state of body. Since no reabsorption, this also partially explains why administering albumin and raising capillary oncotic pull never really leads to reversal of edema in lungs in ARDS. Beyond the sub-glycocalyx layer, water then moves into interstitium through tight endothelial junctions, larger pores, fenestrae, or large clefts depending upon the location. The major part of body including soft tissues, muscles and neural tissue have a continuous endothelial lining covered on luminal side by the continuous glycocalyx. Here, water movement outwards is through tighter spaces at very high velocity, so other molecules simply cannot move back in easily. Consider it a one-way traffic like in this picture. However, in glomeruli there are fenestrae, and still bigger pores and clefts are present in liver, spleen and bone marrow, where glycocalyx is discontinuous. Since space is large, free movement of water to and fro along with proteins and larger molecules exists with no effective colloid oncotic pressures or semi-permeable membranes like in this picture here. So in steady state, as previously explained, lesser fluid moves out and no reabsorption occurs at capillary level, especially at continuous endothelial type. Exception to this no absorption rule does however exist at acute hypovolemic stage, where capillary hydrostatic pressure becomes acutely subnormal. At this stage, autotransfusion of about 500 ml fluid occurs possibly due to compaction of the subglycocalyx layer. As seen in the graph below, when pressure at capillary level falls, the net reabsorption occurs, which self-limits at point B. This is when oncotic pressure within vessels dilutes and reduces due to autotransfusion. A new point of filtration almost close to zero is set at point C as indicated by arrow. So a new steady state of transcapillary flow almost close to zero is set at acute subnormal pressures. At this point, crystalloids and colloids, if given, will have 1.5:1, meaning 65 ml of colloid is as good as 100 ml of crystalloid, until the volume is repleted enough to bring the capillary pressures to normal or supranormal. If you continue then to give fluids, colloids and crystalloids both will raise the capillary hydrostatic pressure, further leading to edema. But since colloids will keep the oncotic pressure stable, while crystalloids will dilute and reduce the colloid oncotic pressure, the edema and outward filtration will be more prominent with crystalloids. The endothelial glycocalyx gets destroyed in sepsis, inflammation, and future target of effective fluid management is based on measures to keep this endothelial glycocalyx layer secure. So now we have the answer to these questions, something a simple traditional Starling principle wasn't able to explain. Today we have updated important physiological points which will set foundation for the coming episode. In the coming episode, we head towards the pharmacology of fluids and how they affect tonicity, electrolyte shift, and acid-base balance. See you next time.